The webinar was scheduled for the end of August, but with the festival season and there was no further webinar, so we just wanted to put it in such a way that we could combine it between August and September. This is going to be the last webinar before our West Zone UCCon at Indore. Now, it's a very interesting topic about stones and PCNL. As we all know, stones are the bread and butter, if I have the liberty to say that, bread and butter for a urologist. Kidney stones more so. And with the invasion of so many other modalities like RIRS, etc., PCNL should have a place to hold its own. Now, PCNL, it's only 4 alphabets, but it's a very tricky operation. And to navigate you through all the tricks, how to reach the stone, how to sort out the problems, we have accumulated an excellent faculty from our zone. So we hope you all get some good messages after the webinar is over. With these few words, I hand it over to our past president, Dr. Jackie Lal Malani, to start the meeting. Jackie, over to you. Jackie, you are muted.
Sir, unmute yourself, sir.
Okay. So, good evening, everyone. Thank you, Ulas, for having this meeting today. And I'm all looking forward to listen what's different, what has changed in PCNL over the last few years. Of course, as you rightly pointed out, there's a big challenge from RIRS. There is a big challenge to the treatment of PCNL. And PCNL also has changed by going micro PCNL and further changes which are going on now. So without much ado, I think I will request you to start the meeting.
Thank you. Gaurang, you can make some intro.
Yes, good evening, friends. This is not the last seminar before West Zone UCCon. In fact, this is the beginning of the West Zone UCCon. Dr. Ullas has come out with an innovative seminar, and I'm sure it will give lots of tips and tricks to perform PCNL in near future. So all Indian urologists, they are very good and very well versed with PCNL. But this will help us in our day-to-day practice. And I will request Ullas to start the seminar.
Okay,
sir,
thank you, Gaurang.
Sir, I'll just take one small moment to remember our current president, Dr. Kandar Parikh. I guess he has voluntarily excused himself because if he is their pioneer of RIRS, there will be a lot of debate.
And by the way, he is in Nepal and he is performing RIRS at this point of time. Anyway, right. So let us start the proceedings. Whenever we talk about a PCNL, let us start from the basics. The basics are what all instrumentation is required. With a plethora of instruments, Dr. Parimal is going to tell us exactly what are the basic requirements, what are the options available in performing a PCNL. Dr. Parimal, over to you. For your first talk, the time given to you is 10 minutes. Unmute yourself, please. Parimal, you are muted. Rohit, sort out his problem.
Yes.
Yeah.
Yes. Okay. Good evening to everyone. Thank you for inviting me for a presentation on armamentarium in PCNL. I am starting my presentation. So armamentarium is a time to have something new, or there is always a bargaining between a money and finding a new things. There is no conflict of interest. I will be going by these topics. So first thing is initial puncture needle. Initial puncture needle is an 18 gauge diamond tip needle. It is also comes in an eco tip needle where there is the tip is ecogenic. So whenever you use an ultrasound for a puncture, it will be helpful. There are two sizes are available: 15 centimeter, which is what we really routinely use, and another is a 20 centimeter size. The 20 centimeter size is useful for obese patient or a deep anterior callosis, supine PCNLs, or when you do a second puncture or you want to puncture from the M+ seat or do a Y puncture when another M+ seat is blocking your way, in that case is 20 centimeters needle is useful. Another is a fascia cutting needle. Fascia cutting needle is a needle which has a hollow tube which can be guided over the guide wire. So after the initial puncture is done, when you want to cut the skin and the fascia inside, the fascia cutting needle can be useful, especially in the cases where there is a previous open stone surgery has been done. This is very helpful in that cases. Then comes in an Alcan cannula. Alcan cannula is mostly used for putting a safety guide wire or a second guide wire beside the first track, and it also can be used when there is a plastic dilators are very soft and the kidney is stout or an open stone surgery has been done. In that case, Alcan cannula is very helpful to dilate the track initially. Then once the guide puncture has been done, then next is a guide wire. A Terumo guide wire is either a straight or angle tip. The advantage of Terumo guide wire is it's a kink resistance, but a new Terumo guide wire is very slippery and you have to be careful in that. Another most commonly used guide wire for a PCNL track is PTFE wire. But the problem with PTFE is when it is broken or it's a kink, then that kink cannot be straighten up and you have to do another puncture, and it makes life difficult for us. Then comes a track dilatation. We have multiple plastic dilators which can be run over from a 6 French to a 12 or 14 French, whereas another is a screw dilator. There are concerns with the damage of parenchyma with the screw dilator, but it is most commonly used dilator at present. Then there are the track dilatation is done either in a single stage or at a multiple steps. Most commonly performed procedure for is a Alcan telescopic metal dilators. Another are the single step dilator or either a mini perk dilators. This was the M+ dilator set which was previously available and mostly now not available. The disadvantage of this M+ dilator set was that it has to come out, every dilator has to come out and another dilator has to go. So that keeps the PC system with the bloody and that causes a lot of clots in the PC system before we go in. So it is almost ruled out. The advantage of Alcan telescopic metal dilator is that these dilators can be used when there is a very less space is required. Even in a PC system where is full of stone or there are the callosal diverticulum, in that cases Alcan metal dilator helps very much in compared to single step dilator, which has around about 7 to 8 mm front area, which requires some space to have a track dilatation. Another are the metal dilators which are used in a mini perk or you can call as a super perk. Then the track maintenance. Track maintenance is what we mean is by once we have dilated the track, we have to maintain the track till the procedure is over. In that cases, we routinely commonly use an M+ seats. M+ seats are a plastic dilators and it's sometimes malleable. So whenever you use a plastic M+ seats, the stones which removes, sometimes if it is not fitting to the size, the M+ seat can be moldable and in that cases the stone can be removed. Another are the metal seats which are non-malleable. It can be either is a mini perk seats or a super perk seats which are commonly used. Now we come to as a nephroscopes. There are two types of nephroscope we basically have. One is the rigid nephroscope and another is a flexible nephroscopes. The rigid nephroscope can be further divided into three same system. One is a rod lens system, another is the fiber optic cables, and the latest and the newer one is a chip on tape technology. The flexible nephroscope routinely now coming are the chip on tape technology. Fiber optic has been given up. So we can divide the nephroscope in three parts. Standard nephroscope 22 French, slender nephroscopes or a mini nephroscope, they are less than the 15 French. So what are the factors which can affect the choice of your nephroscope? The size or diameter of the scope, which scope you have, that if what the dilatation you want, it decides the choice of your nephroscopes. Viewing angle, some nephroscope has a typical viewing angle which are comfortable for some and not comfortable for you. So you need to decide which angle of view you want to use. Then there are some scopes which is half moon, round, oblong or rectangle. The different shapes of the seats or a shaft is there. Then you need to check before what are this, and then is a parallel or offset set. So this is a standard nephroscope which has a half moon design, mostly made by the stores, and it requires 24 or 26 seats. Then in another is a universal nephroscope by Wolf. It is having 22 French outer diameter, require minimum 24 for size sheath, and it has a 20 degree of angle of view. Then is Olympus. The Olympus has come up with a newer nephroscope which has a rectangular shape. So you need to be comfortable with that shape to going into PC system by using it. And second thing is it is also having a 30 degree viewing angle. So the vision during the PCNL may be not in front, but it is a 30 degree down like a cystoscope. It also can be used as a cystoscope, but it has a square angles. So who would prefer the standard nephroscope? Those who are doing routinely 24 or larger tracks only can have a standard nephroscope. Large burden stone or doing lab stagon routinely. Department with a huge workloads, because all the slender scopes or mini scopes having a significant wear and tear. So in the department, it is where there is multiple residents are working, a lot of work burden is there. These are the workhorses for this. Then comes a slender nephroscope. Routine is a Storz nephroscope by 19 French. It has a 6 degree of view. Only problem with this scope is it has a very small circle of view on the screen. So it has to be taken care of previously. Then is a Dresden. Most commonly, most favored nephroscope of all the urologists is a Dresden nephroscope. It's 20 French. It can easily go into 22 French plus Cs. It has a very good large circle on a monitor and it is comfortable viewing angle also 12 degree. Then as the MIP-L, and another scopes is UMD. It has a 19 French diameters. So who would prefer the slender nephroscopes? It's prefer in the smaller tracks. Those who having a very not much large stone burdens, or it has to be in a second scope in all department. If you have a larger scope, you have to have a second scope. You have to have this. And it is commonly used now by most of the people who are doing PCNL for many years. Then comes a mini pug. The standard mini pugs, we have a Storz mini pug, 12 French. Olympus mini French is a 13 French. And then also comes a UMD mini pug scopes. Then comes a super nephroscopes by Dr. Kaushik, which has a 3 different diameters, 13.5 French, 16 French, and 19 French. It's a chip on tip technology, rigid scopes. An inbuilt recording system is available in this. Then comes a flexible nephroscope. The flexible nephroscope has a 13, the newer flexible nephroscope has a 13.2 French diameter and it is a chip on tip technology. Angle of view is 0 and it has a deflection on one side is 210 degree, but on another side is only a 13 degree. You can see that the staghorn can be cleared by this flexible nephroscope by a single puncture because it has it can be molded into all the calyces. You can see the flexible nephroscope used in a upper calyces from the lower calyces. Now comes to the graspers. The graspers are having a 3 type of grip. One is a tri-prong or a spring-like action. Another is a U handle, or another is a alligator-like forceps. There are 3 types of forceps. One is tri-prong, biprong, and alligators. The tri-prongs are grasped like a basket and is releases. So if you catch a larger stone fragment by a tri-prong, you can always release it. It is not useful for gripping the wires and clots. The biprong is the most commonly used grasper, but it requires some space to open. So whenever you're using biprong forceps, there has to be some space to open the biprong forceps. And third is an alligator forceps. It is sometimes used when there is an underdilatation. You are almost at the mucosa and there is your track is not, your implant is not into the PC system. In that case, this alligator can be used to further dilate the track and put the implants in. Then there are 4 types of suction available. One is a laparoscopic type suction, which is have a laparoscopic type action. Another is a trumpet type, simple, or sometimes there is a suction used with the lithotripsy probe in situ, which is most commonly used by many people who are trained at Nadiyar. Then comes a lithotripsy unit. We have a 3 parts. One is a pneumatic only, another is ultrasound plus pneumatic, and the newer one is a triology, which causes ultrasound, ballistic, and the suction effect with it. These are all, triology is a very advanced machine, and it is mostly used, commonly used where the advanced laser centers are there. So what are the factors which can affect the lithotripsy choice? We have to see for the lateral vibration of probes, effectivity of the lithotripsy probes, and most important is availability and repair and service at your center. These are the accessories for the lithotripsy attachment. You can have a central oxygen supply and direct connecting tube, so it can be used in a central oxygen can be used for a lithotripsy machines. The laser is always a debate. Which laser? The laser what you have is useful in PCNL. Either you have a laser, holmium laser, TFL laser, whatever laser. All lasers are good, but given a choice, holmium scores better for a PCNL or a mini per in compared to TFL. What I believe in generally. CM is a choice. Cost is the most important choice by selecting a CM. Thank you. This is all for armamentarium for PCNL.
Thank you, Parimal. That was very precise, and one starts getting aware of what are the various types of instrumentation and armamentarium available for doing a PCNL. Now, once we embark on the PCNL, it has always been maintained that access is everything. Once there is complete proper access, the rest of the things are very easy. To tell us exactly how to get a correct access, we have Dr. Abhijit Patil from Nadiad, MP UH Nadiad. Over to you, Abhijit.
Well, am I audible and visible, sir?
Absolutely.
Well, thank you, Westzone and Ola Sate, sir, for this opportunity. So, as it rightly said, access is everything. Why? Because getting a particular access is an extremely important aspect because kidney is a highly vascular network. And if a wrong puncture can lead to vascular injury and a catastrophe. And why all this fuss? So if you see, if you get a right puncture through the tip of the calyx, then it is okay. But if you go slightly, if you have an infundibular puncture or a wrong puncture, then it will cause bleeding during the procedure and also may lead to malformations and may lead to bleeding post-operative. So what is ideal puncture? It is a puncture which is straight from skin to the papilla and the target calyx, and that is how you gain a proper access into the pelvic calyceal system, and the ureter, the glide wire can be packed into the ureter or an upper calyx. What is an oblique puncture? So if you go an oblique puncture, what will happen is that you may hit a blood vessel, and that can lead to bleeding, and it may become your surgery may become very difficult. So, and again, an importance of wrong access is that suppose this is a point on the skin. Now you thought that the stone is in this calyx, but now you understand or you realize that the stone bearing calyx is this. Now you don't change this a point and try to gain access only through this point. What will happen is that you may be able to pass the glide wire, but once you remove your needle, puncture needle, this will lead to a zigzag tract. And now when will all the problems start is once you start dilating this tract, now the real problem starts. So this leads to kinking, and this wire will lead a kink over here. If suppose if you manipulate and try to get away with this zigzag line and you enter the pelvic calyceal system, you dilate it, you put an implant seat, now you clear off this stone. If you have to go to this stone, what will have, you will have the renal torque and will lead to damage of this parenchyma over here. Now with this, though your access may be whatever it is, but once you try to clear off both the stone, you will lead to potential laceration of the parenchyma and bleeding. So this is a very good animation which tells about the importance of a right access. So which calyx to puncture? An ideal calyx is which facilitates a complete clearance of the calculus with no or minimal complications. Now, how do you identify the posterior calyx? So suppose you are doing a prone PCNL, you instill your contrast in the pelvic calyceal system, then your dependent anterior calyx will fill first, and then the posterior calyx. So the posterior calyx will be less dense on your fluoroscopy. Or you just instill 5 to 10 ml of air through a urinary catheter, and it will enter into your posterior calyces if the patient is prone. Or what you do is if your C-arm is rotated towards the surgeon, the posterior calyces will go away from you or they appear shorter. And that is how you can identify the posterior calyx. So again, an importance of why and proper puncture is required. So suppose this is a complex trigon stone that you have and you want to clear this off in the minimum punctures. So if you choose this track, so if you keep this as a primary track, then majority volume of your stone would be taken care of. So that would be a primary track, and rest of the calyx would be either favorable or unfavorable. So unfavorable calyx would have an acute angle from the entry track, narrow infundibulum, or larger stone burden. So suppose I am operating this case, so my primary puncture should be this tract, followed by this and followed by this. So this is how I'll park my glide wires, and then in that sequence I'll dilate and get the stone clearance. Now access to the kidney can be fluoroscopy guided or an ultrasound guided. Fluoroscopy guided can again be monoplanar or a biplanar. So as you see from this video, so this is an incorrect puncture. So this your needle has gone through the pelvis, which is totally not acceptable, because once you dilate, it will create a pelvic perforation. Now this is how you just correct that puncture, and now you can puncture through the calyx. So this is what a correct puncture would look like. Again, an example. So you took a puncture, now you instill contrast into it, and as you run through this video, you suddenly understand that this is an infundibular puncture. So this is not a correct puncture. If you dilate this, you will have bleeding during a surgery or postoperative. So then this is how the correction is done. So instead of that infundibular puncture, you had this calyceal puncture, and this is how you can correct your puncture. Now, monopolar puncture. How does a monopolar puncture does is that, so with the experience of the surgeon, suppose you understand that this is a calyx. So with a
Yes.
certain skin entry point and with a certain angle, you go inside your calyx. Now you are inside this calyx. So now what can happen? Either you are inside or outside. How do you
Okay.
understand is,
What
so
about you wanted?
so this is your same point of puncture. Now this needle that you see inside your calyx could be either above the calyx, below the calyx, or if you see an indentation of the cup of the calyx, then it is in the correct plane of the puncture. So monoplanar says that with your experience, you choose a point of puncture on your skin and an angle of puncture, and you see as you go inside, if you have an indentation of the cup of the calyx, you're correct, and then you hit that calyx. That is what a monopolar puncture is. So if you see in this video, you can see the cup of the calyx being indented, and now you insert your needle into it, and that is how you get a puncture. Again, an example of how a monoplanar puncture is being done. You slightly land, and what happens is that you have this jiggling movements, and once you have this cupping, you insert your needle into it. Now, even with this, there is a problem. Now, what you can do is you can use your biplanar. So, with your 0 degree, I have punctured this calyx. Now, with this 0 degree, it seems that I am inside the calyx. So, what I have to do, I have to check it in 30 degree. So once you can see this fluoro movement, once I do this 30 towards towards me or the surgeon, suddenly this needle goes towards the spine. So if this is towards the spine, you have to go anterior. Now, so as you see, I've gone anterior. Now again, when I do a 30 degree, you see this needle is still in the same calyx. So if your tip of the needle is in the same calyx in 0 or 30 degree, that is in two planes, then it is certain that you are inside the calyx that you intend to puncture. Now you can see the glide wire which will go clearly from this calyx into the pelvic calyceal system. And you want to remember how to remember it, just remember me. So if your needle goes away from the spine, go posterior. So remember me for this. Abhijit. Other technique is a bullseye technique. So here what you do is that you, to reduce the radiation, you hold your puncture needle with two artery forceps. This is your intended calyx. Now you make it like a bull's eye, and this has to be in 30 degree. Now once you go inside, now how deep you have to go, that you have to check with a 0 degree. Now once you do a 0 degree, as you can see, I can see that my needle is still in the same calyx. And now if I put my glide wire, it will go into the pelvic calyceal system. I hope it is quite clear from this video. Now coming on to the ultrasound guided puncture. The key of ultrasound guided puncture is that once you hold your probe properly, all your calyces pelvis should be in the same line, and you can see this needle which is going through this and the tip, and once you remove this, you can see a clear jet of urine. So the benefit of this is that once you start from posterior to anterior, the first calyx that you see on ultrasound is your posterior calyx. So it helps you understand the posterior calyx the most. And also, if you are well versed with ultrasound, if you switch on the Doppler, it may help you to avoid the major vessel and cause less postoperative bleeding. Now, this is a video which you can see. So the probe is kept and you screen. So as I said, all your calyces and pelvis should be seen in a single picture. You mark, you attach so this is how you probe the needle attached with an attachment. Now you see all the calyces. You see this is the stone. Now you try to see from here. The needle is traversing through all the layers of the abdomen through the cortex, and you see this is the stone and this is the tip of the needle. It is trying to hit that stone. Now this is a completely if it is said that renal puncture is a blind procedure, if you use this technique, it is completely under vision, and you can suddenly see a beautiful gush of urine coming out. And if you pass a glide wire, and if it's a dilated system, you can very well see that glide wire being coiled into that pelvic calyceal system. Now, what is so after all this importance of why a right puncture and how to take a right puncture, this is a very good study which identifies the risk factor of severe bleeding requiring angioembolization after PCNL, and the 21 patients who underwent angioembolization after PCNL, incorrect puncture was seen in 66% of the patients who underwent angioembolization. So they concluded that incorrect renal puncture was related to severe bleeding requiring angioembolization after PCNL. So the results emphasize the importance of basic principle of renal puncture for PCNL. Whatever technique that you use, if you do it correctly, it will lead to the same result. So at the same conference, this was a puncture done by Dr. Parimal by a bullseye technique, and this was me by a monoclonal technique. We are both in the same calyx, the cone of puncture, and we still had the clear urine. So whichever technique you are well versed is, try to use that technique. But if you follow the proper principles, then you can puncture a desired calyx. If you don't understand this monoclonal, then you can see the two planes, which is 0 degree and 30 degree. But that golden tip is that the tip of the needle should always be in the calyx in both the planes. Thank you.
Thank you, Abhijit. That was a wonderful presentation. And as we all know, that to access a normal kidney, a normally located, normally positioned kidney, this was fine. But so many times we come across malformed kidneys, malrotated kidneys, and ectopic kidneys. But still, those stones require a PCNL. How to enter such kidneys? Our expert, Dr. Pankaj Maheshwari, is going to enlighten on this. Over to you, Pankaj. Pankaj, you're on.
Yes. Is my screen visible?
Yes, visible. Absolutely. Go ahead.
Right. Thank you very much. Thank you, Ulas, for this kind invitation. Indeed, a fabulous program and a very well chopped out program. I will be concentrating on how to make access in malrotated kidney. As has been told to us, access for PCNL is probably the most important step for PCNL. The war of PCNL is won or lost based on how well we make a tract. Again, making tract is usually difficult because here we are trying to visualize a three-dimensional anatomy in a two-dimensional fluoroscopy. Hence, making access has the steepest learning curve. Although different access techniques have been described, what every technique would want to do is give you a short and straight access to maximum stone bulk. That is obviously the aim of our procedure. I would want to enter from the posterior lateral direction because this is probably the vascular place in the kidney. I would want to go through the center of calyx rather through the papilla, because here the arteries will be end arteries and the risk of bleeding would be low. Definitely, I don't want to puncture the renal pelvis directly. I want to go through the renal parenchyma. Now, all tracts, whether I go from upper calyx, middle calyx, or lower calyx, the direction of tract should be through the center of the renal pelvis. When we are aligned towards the center of renal pelvis, we know that the blood supply to the kidney starts from the center of the kidney and fans out peripherally. So any tract I make which is directed towards the renal pelvis would be parallel to these blood vessels, and hence the risk of injury would be less. And definitely, we don't want to injure any major blood vessels or injure any surrounding organs. So if we make this short table, ideal tract would have Y for all these 6 aspects, that is posterior lateral axis, through the center of calyx, through the parenchyma, directed towards the center of renal pelvis, avoiding blood vessels, and no injury to the surrounding organs. Anomalous kidney present a very different challenge. The reason being, though these are normally functioning kidneys, they are anatomically different. So the orientation of the renal pelvis, calyces, the angle of the kidney, the entry of the blood vessels, everything would be different. So hence, PCNL in these cases would be challenging. We would need to really decide where we enter to get the best access to these stones. Further, we know that the vasculature is aberrant. So it is important to know where the blood vessels are coming from so that we try and avoid these areas. The relationships of the organs will be different. Many times a pelvic kidney or a lower of, yes.
I think is it the same slide, because the slides don't seem to be moving?
Oh, I'm sorry, because on my table it is moving.
Now we got the next slide. We were having only the first slide.
Should I start again? Because
yes, I think so. You should go back.
Okay.
Yeah.
So I'll just show you the slides. Can you see the slides moving now?
Yes. Now it is okay.
So as I had said, making the puncture is the most important step, because here we need to visualize the 3-dimensional anatomy in a 2-dimensional fluoroscopy. Various different ways of making a puncture, but the ideal puncture would be, these are the criteria I've said. And this is the small table which says that there should be yes to everyone. Posterior lateral entry through the center of calyx, through the parenchyma, directed towards renal pelvis, avoiding blood vessels and avoiding injury to surrounding organs. Anomalous kidneys are different kidneys, though functioning normal, but anatomically different. And hence, the difference is that the renal and the calyceal orientation may be different. The position of the calyces in relation to the renal pelvis and upper ureter may be different. The vasculature is different, so we need to understand where the blood vessels are coming from. Quite often, these organs would be surrounded by bowel, so we need to prevent injury to bowel. And these kidneys sometimes can be immobile. Many times in PCNL, we take help of the slight mobility of the kidney to reach from one calyx to other. In the immobile kidney, our movement inside the kidney could cause torque on the kidney and lead to increased bleeding. So, though PCNL in these cases may be challenging, this remains the treatment of choice for most stones, because as compared to ESWL or RRS, the stone-free rate of PCNL are highest. The challenge is always in the access. There is a study which said that failed access is nearly 2.5 times higher in patients with renal anomalies as compared to normal kidneys. So definitely this needs a proper planning. We need to get as much information as we can before we start the procedure. Just doing the intravenous urography would not be sufficient. It will tell you stone, orientation of the PCS, but will not give you a lot of information about the vascularity and the surrounding organs. CT scan becomes absolutely essential, because we would know how deep the tract is, how the calyces are oriented, where the blood vessels are, and hence help us in planning the procedure. Again, on CT scan, we can do a 3-dimensional reconstruction. So we also understand the angles and we can decide which puncture would lead us to which part of the kidney. If we know the details more, the more we know, the less we injure and the less is the risk of bleeding. Now let's look at horseshoe kidney. We know these are kidneys which are fused at the isthmus. they are more lower than in the normal position. The orientation of the kidney, instead of the upper pole being medial, the upper pole is lateral. Now, if I try to puncture laterally, definitely I can't puncture laterally because the calyces many times are medially oriented. I would definitely want to go through the center of the calyx. Can I always go through the parenchyma? Yes, I would want to go through parenchyma. Can I always aim for renal pelvis? No, because many times in horseshoe kidney, the renal pelvis is very anteriorly positioned. So my tract could be through one of the calyx along that infundibulum, and the renal pelvis would be anterior. Definitely, I would want to avoid blood vessels, and I would want to avoid injury to surrounding organs. Now, horseshoe kidney, the highest risk of surrounding organ injury here is injury to the pleural spaces, because the preferred access is through the upper calyx. Upper calyx being more superficial and posterior, the tracts tend to be more medial and vertical. We know that for upper calyx access, if the tract is in the lateral half of the intercostal space, the risk of pleural violation is very less. Here, because we end going in the middle half, medial half of the intercostal space, there is a higher chance of pleural violation. Though pleural violation and pleural fluid collection may not have much significance, but this is something we should be aware of. This remains the best access because this access will give us a very good access to the upper calyx, renal pelvis, PUJ, and sometimes it may be possible to go down the upper ureter. You may even be able to reach the middle calyx, but it will be impossible to reach the ischemic calyx. Middle calyx puncture can be done sometimes as a second tract, sometimes to flush out small pieces in the middle calyx, but definitely we should not make a lower calyx access because it would go through a very thick amount of parenchyma. Again, it is important to remember that just having rigid nephroscope, your success will be low. It is better to have support of flexible nephroscopy. Extra long nephroscopes will be needed because the length of the upper calyx infundibulum is usually long. The kidney is much longer than a standard kidney. So reaching in the renal pelvis and towards the isthmus may sometimes be difficult. Now let's look at this patient. Now this patient had a large stone in the ischemic calyx. There is a history of pyelolithotomy in past. Now, from where should I enter this kidney? If I come from the upper calyx, turning towards the ischemic calyx will be difficult. For a flexible cope, this tract is very long, and further there is an infundibular stenosis. Again, the stone is very big for flexible nephroscopy. RIRS, the angle is more than 90 degrees. So here we needed out-of-box thinking. What we did was we did a laparoscopic transperitoneal percutaneous nephrolithotomy. So a lap assisted, I went anteriorly. This way I could avoid the major vessels which are posteriorly oriented and make a puncture precise in the calyx, in the infundibulum, in the isthmus, and then reach the stone. So sometimes in difficult situations, out-of-box thinking to really tackle the situation is important. Ischemic calyx can be approached by flexible nephroscope. Lap assisted would be a rare need. Small peripheral calculi don't try to make second tracts often. Leave them for either flexible nephroscopy, ESWL, or RIRS later on. Let's look at malrotated kidney. Now the kidney is well positioned, but the orientation of the pelvic ileal system is different. Again, planning of PCNL would be done on CT scan. I would want to go through posterior lateral. I cannot go through posterior lateral because posterior lateral, the calyces are all directed medially. I cannot go medial because there are blood vessels here. I would want to go through the center of calyx. I would want to go through the renal parenchyma. Directing towards renal pelvis may be difficult. Definitely, I would want to avoid blood vessels and avoid surrounding organ injury. In kidneys like this, the treatment will be like horseshoe kidney, and upper pole access would probably be the safest and best access for this kidney. Bifid renal pelvis, I have just mentioned this because though this really doesn't come under anomalous kidneys, but here the success rate of ESWL and RIRS both is marginally less in bifid kidney. Sometimes in bifid pelvis, there is not enough space for your flexible scope to deflect. So have a higher threshold for PCNL and a well-done PCNL can give a good success in these patients. Renal ectopia, again, a very interesting anomaly where the kidney refuses to ascend to its normal position. Because it doesn't ascend, the orientation of the kidney and its renal pelvis and calycis is different. Blood vessels are different. It may be anywhere from renal pelvis to thorax to opposite side. The treatment would need to be planned well. And again, as we have discussed, we will need a good quality CT scan. Now look at this kidney. From left, the kidney has moved to right. So cross-fused ectopia. The kidney is aligned horizontally. It is not vertically positioned. The upper calyx is directed medially, so I can't enter the upper calyx. I will be forced to enter the lower calyx. Now on CT scan, we realized that in the back, on the lower aspect of the back, there was a window in which there was no intervening bowel between the lower pole and this calyx. So a precise puncture from there, which was CT controlled, could be done, avoiding injury to the blood vessels. So in such situation, there would be no preference to any calyx. You would choose a calyx which is safest and gives access to the maximum stone bulk. Again, going by a formula, posterolateral not possible, center yes, through parenchyma yes. Sometimes you may decide to do a lap pyelolithotomy instead. Directing towards renal pelvis may sometimes not be possible. Avoiding blood vessels may be difficult, but we would try to do that. Avoiding surrounding organ injury, again difficult, but if necessary, do a lap-assisted PCNL, which will avoid injury to the bowel, or as in this patient we did, a CT-guided puncture could be a good idea. Pelvic kidney with large stones, when such single large renal pelvic stone is there, then pyelolithotomy is a good option, but otherwise PCNL can be done. The access is difficult because this kidney is always surrounded by bowel. The access will need to be anterior. You cannot go posterolateral. You will try to go through the center of calyx, but not push for it. You will try to go through the parenchyma, but as I've said, pyelolithotomy can be done. Directing towards renal pelvis may not be possible. You will want to look for the blood vessels and look for surrounding organs. Because there are surrounding organs, primary PCNL posteriorly is obviously not possible. This will need to be done laparoscopy guided. There are reports of access to this kidney through sciatic foramina, but this is more for theoretical knowledge than really a practical thing. Two teams are needed, a laparoscopy team which keeps the bowel away and a nephroscopy team which will make puncture. The puncture and tract dilatation is done both under fluoroscopy and laparoscopy guidance. The lap team just keeps the bowel away when we are doing a standard percutaneous access to the calyx that we want. All dilators and access sheath should be followed from the skin till where they enter. At the end of the procedure, a nephrostomy tube is kept. You may keep a drain and then remove the tube sequentially once the patient is stable. So PCNL can be safely done in anomalous kidney. Proper planning, visualization, and understanding the anatomy is very, very important. Thank you.
Bunker.
Ulas?
Yes.
Ulas, did I put you to sleep?
Okay. Am I audible now?
Yes. I thought I was so boring that I put you to sleep. Ulas, you are muted.
Am I audible now?
Yes, you are.
Okay. No, then you missed out when I was muted. I just said it was brilliant as usual. Anyway, we'll keep questions at the end. We now hand over to Dr. Amish Mehta. He is going to talk about access in a diverticular stone, which is a very tricky thing. And let's see how Amish is going to tackle it. Over to you, Amish.
Thank you, sir. Am I audible, sir? Hello. Hello.
Yes, you are perfectly audible.
Thank you. Thank you so very much, sir, for this excellent opportunity.
Yes, audible.
without much ado, we'll proceed. I think both the previous presentations have done a great job and have reduced my task rather for this tricky situation. I would say once you know how to perform a PCNL, you already know how to deal with a calyceal diverticulum. It's very well said already that access is actually everything. And as what is very nicely depicted by Dr. Maheshwari sir, that once you identify the anatomy well and you know the principles of PCNL to be followed in this particular situation, I think you have done the job here. So what are the basics about renal calyceal diverticulum? They are essentially the eventuations of PCS, which are lying within the renal parenchyma, are supposed to be congenital. A theory behind them being secondary due to inflammation and obstruction usually is not found to be in place. They are outpouchings which are communicating through a very narrow opening with the main PCS. These are lined by non-secretory urothelium, and they fill passively with the urine from PCS when it gets filled. There are certain classifications for calyceal diverticulum are available. Just to have a basic idea about them, an essential classification is into dividing them into types. The type 1, which is more common, are the diverticuli which communicate with minor calyces or an infundibulum. The type 2 diverticuli are supposed to be larger, more likely to be symptomatic. They usually are located in the central part of the kidney and supposed to be arising from the renal pelvis or one of the major calyces. A few of the historical classifications, they used to be in place in terms of defining the treatment plan, but with the recent treatments available, they are not much in place. As such, the renal calyceal diverticuli pathologically are supposed to be very uncommon. Majority of them are found in upper calyceal system with a propensity in female patients. They are supposed to be asymptomatic in most of the time. However, once they are found with the stone, they often become symptomatic. Actually, the calyceal diverticular stones are the reason that we usually come to know about that there is a calyceal diverticulum. The stones which are found in the calyceal diverticuli are supposed to be the same as they are found in rest of the PCS. About diagnosing the diverticuli, ultrasound usually comes handy. We can pick it up in office itself. However, if the stone is entirely filling the diverticulum, sometimes it might not be possible to identify the same. Mixing it with a simple cyst or a stenosis calyx is common. Ultrasound particularly has got a very special place while trying to get an access to the diverticular stone while performing PCNL. Though uncommonly being performed nowadays, an IVU, if comes to your hand, we are supposed to follow delayed films, which is going to show the calyceal system essentially filled with urine, and then only we'll be able to pick up a diverticulum being filled. We can have a nice example over here that this particular stone here is seen in the diverticulum in the upper calyceal system, and at the 30-minute plate in prone position, well, the PCS is very well filled. Still, there is no filling noted in that region. CT urography, as we all know, is a standard of care for diagnosis and helps in planning the treatment. It is very important to identify the detailed anatomy and trying to find out the possible communication with the PCS. Particularly, it is important if we can go on to the console and see the entire urography imaging, because that is where you actually plan your treatment. A few of the examples here we can see on a plain CT that there is presence of this diverticulum with tiny secondary stones inside. Now, this particular situation is very important to be identified because this is where an ultrasound guided puncture might be just helpful. As this diverticulum does not show presence of stone all in all, a stone guided puncture may not be successful. The same imaging in a failed PCS shows gradual filling of some of the contrasts over here in the dependent position. Another such example is an ectopic kidney left to right cross-fuse ectopia. Though it was not very much visible on a plain film, the contrast study shows it all. As we discussed, steno's calyx can be mistaken for the calyceal diverticulum. However, presence of other findings on a CT, it is less likely to be missed. The presence of rest of the PCS filled with stone, inflammation, or history of previous surgery is likely to give us a clue about steno's calyx. One short way to identify whether it is a steno's calyx or calyceal diverticulum is observing it intraoperatively. We'll discuss this same. Coming to the point, performing PCNL for a diverticulum, I believe it is the best possible way to achieve highest stone clearance rate, and also because PCNL has got the ability to manage the diverticulum itself in order to reduce further recurrences in the future. Before we proceed with PCNL or stone clearance in a diverticulum, one has to be very clear about how to approach it. A very clear three-dimensional understanding of the pelvic calyceal system, any possible vascular proximity in case of very large diverticulum, the parenchymal thickness over the diverticulum. If you are not sure that is accessible with the PCNL, there is no shame, no harm to pick RIRS as an option, particularly for the diverticuli which are located in anterior side, or they are facing when they are facing medially. Once you know how to identify the calyceal position within a kidney, I think the case is half won. Then comes the on-table activity. Yes, it's already said access is everything, the most important factor in the management of a stone anyways. I would prefer a prone position and presence of the ureteric catheter tip in the upper calyx for a better backup in case required. An entry to a diverticulum is just like any other chosen calyceal entry. You already know which calyx to enter from your preparatory CT scan observation. A pyelogram can be either with a contrast, any of the contrast material. I usually prefer an air contrast because here you don't necessarily have to fill the diverticulum, and the stone inside itself is a good guide. Probing or sounding the stone with a needle is the key here. I would again reiterate to prefer bullseye because it gives you the freedom to confirm in different positions that your needle is in place. Many of such times it is very difficult to confirm it otherwise, because hardly ever that you may get any saline or anything coming out of the needle, even if you try. If not sure, using an ultrasound on table is a way to go. Next challenge is to get stabilized inside the diverticulum. Parking the guide wire might be difficult, and use of a J-tip guide wire could be suggested. I would rather say attempting to coil a wire inside the diverticulum is the whole thing you do. If you can park a J-tip, I think any regular Terumo guide wire can be easily parked inside. Good coil inside the diverticulum is enough. There is no point, and most probably there is least possibility that a guide wire would cross the infundibulum into the PCS. Once entry is secured, the dilatation to the stone is supposed to be very careful. Alkane serial dilators are usually the choice. However, I would say possible a single step dilatation would do the job. You can perform mini perk, avoid any further dilatation, and less likely that you're going to destabilize the park guide wire or the system altogether. One such debatable issue is about how to put an M+ sheath. I would prefer parking a bevel tip inside, though it is being recommended that a non-bevel tip can come handy because there is less space inside the system. We would just observe it in one of the videos here. Once the M+ sheath is parked, the case is yours. Clear the stone with whatsoever matter way you are comfortable with. Use of suction can do the job faster. At the end of the procedure, it is very important to inspect the calyceal system. Whatever that you are going to observe inside that cavity is going to tell you whether it is a steno's calyx or the calyx diverticulum itself. All the possible way to be used to identify the neck should be taken care of. Entry to the PCS could be very essential in case a very roomy calyceal diverticulum is identified. We can take this case. Here we can see that there is presence of a stone extending into the PCS, but actually this seems to be secondary calculi located in the upper or middle calyceal system. Here, however, is a nice diverticulum over here with secondary calculi inside, and another secondary calculi located in the main PCS system over here. While getting the access to the same system, we can see here the ureteric catheter parked in the upper calyx. Here is the V-shaped stone presence in the middle calyceal system, and this is our diverticular stone. Rest of the PCS is very well identified. The access in a 0 degree, 30 degree position and 0 degree position. The presence of needle confirmed while actually palpating the stone with the needle. The wire can be nicely coiled inside, and we'll see in the video in the last that all these stones could be very well cleared through the same track over here, in spite of this being a diverticulum. For the diverticuli which are non-posterior, one option is that you can very well access them directly in using the bullseye technique, even if they are in anterior calyx. However, if they are placed medially or not so well accessible for direct puncture, one can get access to the main PCS just like any other PCNL case in an attempt to get a direct access to the diverticular neck. Use of blue spritz technique can come handy if the diverticular neck is not identifiable. Here, one thing is important, as very well demarcated by Dr. Abhijit. While you are trying to get an entry into the PCS in a regular PCNL, your attempt is to get an access along the infundibular axis towards the center of the PCS. While in case of diverticular access, it is not the case. All you have to do is just to enter the diverticulum. Exit strategy. Historically, it has been described in two ways. One way is to ablate the diverticular cavity, fulgurate it and leave it as such without any tubes across, or to dilate the ostium, put a nephrostomy across it in order to get a well-established communication with the rest of the PCS. I would rather say it should be decided on table whether to dilate the ostium to leave it as such or to use any further tubes. Whenever possible, dilatation of the ostium is good. It allows a widespread entry into the PCS, and as we know that it fills indirectly from the PCS itself, a wide drainage will prevent stasis, as majority of them are in upper calyceal system. If the diverticulum is roomy enough, one can leave the coil of the degestant in the diverticulum across the ostium. In case of doubt about the ostial stenosis or any bleeding, one can leave the nephrostomy across it. However, if it is not possible to find the infundibular entry, one may choose to leave the diverticulum as such. However, one has to ensure a good main PC system drainage by all means in all the cases of diverticulum. I believe that is the way to prevent any further leak from the diverticulum. The purpose of showing this video is one, to show that how keeping the bevel tip towards the diverticulum helps. Second is how to identify and get the entry across the ostium. And third is to identify a stenos calyx. As we can see here, even if we come out of the system and stay at the renal capsule, a bevel tip can easily enter the narrow space, which is not possible with the non-beveled end. Presence of Rendel's plaque or looking at the papillae can very well tell us that this is the stenos calyx, and whether it is a stenos calyx or the diverticulum itself, we can almost always be successfully in position to identify its entry into the PCS and attempt to instill dilated betadine or methylene blue inside the PCS and trying to see the egress into the diverticulum itself will tell us where we are actually standing. And we can see over here that an entry is achieved. We can gently dilate the orifice and enter the rest of the system. The another video here to show the diverticulum itself. The previous one was the stenos calyx. Here the stone was cleared. This is the same case as what we see in the last CT plates. The calyceal stones are cleared. Now we are trying to dilate the ostium and trying to get the access to the rest of the PCS. Once the dilatation is achieved, we get the entry into the upper middle calyceal system, and the stone were cleared. Once the task was done, we can see over here to inspect the cavity that there are no Rendes plaque, presence of any spots suggesting presence of stone or papillae. So this is supposed to be the diverticulum. Here we enter through its dilated ostium, and we can very well see the middle calyx, which has got the presence of stone speckles over the papillae. So this is our main PCS. And now we'll see the entry into the system. So this is about calyceal diverticulum management. I believe the take-home message here should be, you assess the anatomy very well, you understand what you are supposed to dealing with, and you decide your plan before taking the patient on table. Once it's done, a steady, swift, and seamless procedure does the job. What you need to know is to get the command on the procedure itself, not the diverticulum. Once you know how to perform PCNL, you know how to deal with a diverticular stone. Thank you.
Thank you, Amish. A very good presentation. We now move on to the next speaker, who's Dr. Gyanendra Sharma. All of us do a prone PCNL, but then there are some situations which demand a supine PCNL. If the patient is very obese or patient has a respiratory problem, something like that, then we should also be aware how to perform a supine PCNL. And over the next 10 minutes, Dr. Gyanendra is going to guide us through the procedure of a supine PCNL. Over to you, Gyanendra.
Good evening, everybody. Thank you, Dr. Ullas and West Zone, for giving me an opportunity to speak on this topic. I would differ a bit from Dr. Ullas that we do supine PCNL occasionally in obese patients. I have in the last 3 years done prone PCNL in only one patient. I have shifted completely to supine PCNL. Now, it has various advantages, and my aim in this talk is to present certain tips and tricks in achieving a good supine PCNL. The first important step is how do we position the patient? And it incorporates the following things. That is, we should mark the posterior axillary line, give a modified lithotomy position because it saves a lot of time, insert bolsters under the scapula and pelvis, confirm on SIAM that our position is correct, and then painting and dripping of the patient. Now, marking the posterior axillary line is the first most important step in supine PCNL because we should always make an entry beneath or below the posterior axillary line. And this marking ideally should be done in anatomical position. I usually do it in a sitting position, and I will show you why this makes a difference. Now you look at the screen on your left hand side and you see that the patient is, but his back is bent. So we are making a line at the level of the posterior axillary line. And then you look at the next where his back is straight and the posterior axillary line is getting marked, which is really posterior to the line which has been marked previously. And when we mark a line, when the patient is in supine position with bolsters underneath it, this line is still much more anterior. So the correct posterior line is the one which is the lowest down, and hence marking the posterior axillary line in anatomical position is of paramount importance, and I usually do it in sitting position. Now, why this is important? I did a small experiment or maneuver. Now you can see here that this is a marker which is seen, which was a wire which was put when the patient was in an anatomical position, and this is the posterior axillary line. Now, if we mark the posterior axillary line in sitting position or in anatomical position, this is the site, and in supine position, this is the site which comes. And if we are going to go just beneath this, the risk of injury to the colon is very high. So this is the line which was marked with the patient in the sitting position. And we need to go just beneath it. And this is the modified anatomical position or lithotomy position that I usually give to these patients because it gives me access to the bladder, as well as I can move by the side, make a puncture, and if need be, put a flexible scope at the same time. Now, what are the bolsters that I use? Now, the bolsters that I use are made up of thermocol. Now, for quite obese patients who are more than 80-85 kgs, the width of these bolsters is about 7.5 centimeter. But for those who are beneath 70-75 kgs, it's about 5 centimeter. So I do not aim to tilt the patient too much. He should be as supine as possible. Now, how do we mark? How do we know that the position is correct? So when you put the C-arm, these stones should not overlap the vertebral column. If they are not overlapping despite putting the bolsters, I feel that is a much more accurate position, because if it is too much of tilt, you are actually going much more posteriorly. This is a case of a child where instead of bolsters, we just rolled the towels and kept it. One can use even saline bottles for achieving these bolsters. Now, this is the position, small video depicting the position. This is the marking which is done. It's on the right side that I intend to do the PCNL. So the lithotomy stirrups are put in such a way that they are virtually parallel to the operating table. The patient's buttocks are then brought to the edge of the table. One leg is kept in a standard lithotomy position, and the other leg is kept as straight as possible. Now, once this position is achieved, as we do most of our cases under spinal anesthesia, the pillows are taken properly underneath the neck. The OT assistants just tilt the patients so that I can insert the bolsters, one inserted below the scapula and the other beneath the buttocks. Though seemingly it seems that we have a very small space, this space is good enough for most of the cases, and there is very rare instance where the iliac blades or the buttocks come in between. And these are the markings of the 12th, 11th rib and the iliac blades, which is mainly for demonstration purpose. I do not usually mark them. And then we take the patient more towards the edge of the table, but not across the table, because the metal bar underneath the table can otherwise then interfere with our C-arm imaging. Most of the times the puncture in a supine PCNL is a lower pole puncture. So the C-arm screen is on my right hand side and the monitor is exactly facing me. And then the draping is done, painting draping. Now, how do we make a puncture in a supine PCNL? As in a prone PCNL, there are two techniques. One is a bullseye technique and the second is a triangulation technique. Now, in bullseye technique, in fact, the C-arm is rotated beneath the table and the needle is aligned in such a way that it forms a bullseye. I had seen somebody doing it in Nepal, but I'm not a big fan of the bullseye technique for supine PCNL, and I think triangulation technique serves the purpose in most of the cases. And again, the principles are the same. We need to determine the site of skin puncture. We need to determine the angle of puncture and estimate the depth of puncture. For determining the site of skin puncture, we need to mark the calyx, which we have to puncture with the C-arm at 0 degree by keeping the needle on the body surface, and the puncture should start below the posterior axillary line. Now, where do we make a puncture? Now, you can see there are 3 star marks which have been shown. The one towards the caudal end is for the lower pole, the other one is for the middle pole, and the third is for the upper pole. What I intend to impress upon the viewers is that your puncture should be farther away from the posterior axillary line if you intend to puncture the upper part of the kidney, and I will illustrate it better in the subsequent slides. Now you can see this patient has had 3 punctures: the lower pole puncture, the mid pole, and the upper pole puncture, which was in fact a supra-11th puncture. Now why this becomes important is, now you can see a marker which is a posterior axillary line. So if we are going just beneath the posterior axillary line in order to puncture the upper pole, the risk of injury to the surrounding organs, that is the spleen on the left side and the liver on the right side, will be very high. And hence, For the upper pole puncture, you need to go at least 2 to 3 finger breadths below the posterior axillary line. You can be about 2 finger breadth beneath the posterior axillary line for a middle pole puncture. And this particular slide will illustrate how this makes a difference. You can see in the first slide on your left-hand side that the lower pole can be punctured by going just beneath a 1 finger breadth beneath the posterior axillary line. For mid pole, you need to be further down, and for the upper pole, you need to be really much more closer to the more down, so that you are more closer to the midline. And for this reason, if you intend to have an upper pole puncture, the tilt of the patient will have to be a bit more while positioning. So this again, this slide illustrates, this was a supra 11th puncture. This will be what would be my lower pole puncture, but this is where I made an upper pole puncture, and this was again a tubeless PCNL. Ideally, in a lower pole calyx, which is punctured about more than 80% or 90% of the times in supine PCNL, the medial most calyx is never punctured because this is very difficult to approach. The angle of puncture, ideally you should start parallel to the floor. And these two videos will illustrate this particular aspect very well. And these are unedited videos. You can see that the posterior axillary line is marked. I have marked the calyx and I am going just beneath the posterior axillary line. The needle is parallel to the floor. I am trying to go in. There is some resistance because of the rib over there, but a slight change in the angulation in the mediolateral direction overcomes this problem. And we go just parallel to the floor towards the calyx. And as the previous speaker mentioned, that if the calyx gets indented, it means that you are right in the right plane. Just go up to the calyx and you can see the free flow of saline coming. I hardly ever have the need of using a 20 centimeter long needle, even in a supine PCNL. 98% or 99% of the times a 15 centimeter needle is good enough. And you can see the glide wire walking into the ureter very easily, and the dilatation is again done in the same direction. Now, how do we estimate the depth of the puncture? Now, the standard principles hold true here. Medial and lateral adjustments are done with the C-arm at 0 degree, and the anteroposterior adjustments are done with the C-arm tilted to 30 degrees cephalocaudally. Now, this is what you see with the C-arm at 0 degree, and we really do not know whether the needle is in the calyx or it is above or below the calyx. So the simple thing to remember is that if the needle is below the calyx, when you tilt the C-arm 30 degree cephalocaudally, if the needle is below the calyx, it means we are too anterior. And if the needle is above the calyx, it means we are too posterior to it. Now, here one can see that the needle is above the calyx. So above means we are more posterior. We need to readjust our needle in such a way that we are exactly in alignment with it, and then the C-arm can be brought back to its original position and puncture can be done. I think I end my talk at this particular point. Thank you so much. Over to you, Ullas sir.
Yes, thank you, Gyanendra. That was fantastic. So precise, so concise, and very easy to follow. I think you have motivated me quite a number of times. So I think I'm going to now routinely start doing supine PCNLs. Anyway, the adult part is over. Now we hand over the mic to Dr. Kishore Vani. He is going to demonstrate what is different when you are operating on a pediatric case. So Kishore, you can take over now. Over to you.
So am I audible?
Yes, you are.
Okay, sir. Good evening, everyone. Thank you, USI West Zone and Dr. Ullas sir for giving this opportunity. Today I'll be talking about pediatric PCNL. I think those who are very well versed with doing adult PCNL can very well do pediatric PCNL. Only two things are required for pediatric PCNL. One thing is the instrumentation, the size of the instrumentation, which is quite smaller than the adult one. And second thing, you have to be really delicate while doing pediatric PCNL because the patient on whom you are operating are delicate. So I will run my presentation starting with some basic things about pediatric PCNL, what precautions we need to take while doing pediatric PCNL, and then a demonstration of a case of pediatric PCNL. So remember one thing, the pediatric patients have highest incidence of recurrences. So our aim should be to have complete clearance in one setting, because anything which is left behind will definitely going to have recurrence of stones and requirement of repeated surgeries. So I think repeated surgeries is not a good choice for the pediatric patient as compared to adult. Repeated sitting is not a good choice for pediatric patient. So try to do patient in a single sitting, try to adapt that modality for that child, which will clear the stone completely in one sitting. Two things has to be remembered while doing pediatric PCNL. The sizes, kidney sizes are very small, so you have to be really delicate while dilating. And second thing is pediatric patient has very less tolerance for blood loss. So you have to be really careful while making the track in pediatric PCNL. So the goal of treating pediatric PCNL patient, pediatric stone patients, and the choice of your treatment should be a best and immediate stone-free rate. It should have a minimal invasivity, the low complication rate, the less procedure, and of course anesthesia time, and the radiation safe protocol has to be followed. And of course, the shorter hospital stay is the key for pediatric patients. There are a few intra protocols we should follow in pediatric PCNLs. That the small access is necessary. Second thing is avoid any risky maneuvers like any angulation or too much torque on the kidney will not be tolerated by pediatric kidneys. So the track has to be absolutely straight. Second thing is, if possible, avoid multiple tracks. Like in adults, we have 3 tracks, 4 tracks, 5 tracks, whatever we want. Adult kidneys are very good at tolerating the tracks, but the pediatric kidneys are not very good. So the multiple track has to be avoided in pediatric PCNLs. The PCNL system has to be low pressure endolithotripsy. That means whatever amount of fluid you are pushing in has to come out simultaneously without increasing the intrapelvic pressure. So the absorption of fluid into the system should be as less as possible. Limit your operative time as less as possible and don't leave any fragment behind. There are 4-5 things we should be very careful. First thing is you have to remember the texture of parenchyma in this pediatric patient is very firm. So when you push the needle pushes the kidney. So you have to be a little gentle on that part. The facial structures are very elastic as compared to adults. So it is always difficult to dilate. So make a good way by making a 11 number knife and make a track through that particular track. The kidneys are hypermobile, so you have to be very careful because many times along with your needle, the kidney pushes medially and your puncture goes haywire. So you have to be very careful, and that has to be very jerky movement at the capsule. Everyone should remember the distance from the skin to the calyx is very short, so there should not be any excessive force because any excess force can put you in a wrong direction, or you can go through and through as well. So always it should be a gentle drilling movements while making the access and track rather than pushing and pulling. So remember one thing, you adapt the child to your scope, but not adapt the scope to the child. So you have to be very careful in choosing your instrumentation while doing pediatric PCNL. There are quite various options available for this. I had experience of 2, routinely in a patient who are above 5 years of old, I always use MIP-M, which is by stores. The nephroscope is of 12 French size and the sheath size is about 13 to 15 centimeter. So that this is the best for pediatric PCNLs above 5 years of age. If the child is below 5 years or below 2 years, then MIP XS is a better option because the sheath size is smaller. which is only 8.5 to 9.5 French. And second thing is the nephroscope which passes through the sheath is 7.5 French only. And laser is must in both the cases. Another ultra mini perc is also a good choice where the sheath size is 11 to 13 French and the nephroscope size is 6 French only. This is also a good choice for pediatric PCNLs. Remember 5 things while doing pediatric PCNL. The surgery is always done under general anesthesia. Prophylactic antibiotic is must in all these patients because most of the patients have infected stones. Hypothermia has a bigger risk in pediatric PCNL in the theater. So every effort has to be done to monitor and maintain the appropriate body temperature. Operative room temperature has to be maintained at the ranges of 25 to 28 degree. So the hypothermia chances are very less. And whatever saline you are using for the irrigation has to be warmed properly. The warming blankets has to be covered the body part which are not in the field of operation. So these are the things which are very important to prevent hypothermia, where this pediatric patient very potential for going into hypothermia. This is the typical position. So rest of the PCNL technique and procedure is same as in adult. As I told you in the very first slide, you need delicacy and a proper size instruments. So always patient is put in prone position. Before putting the patient in prone position, you have to put ureteric catheter, lasers, whatever choice you have, whatever availability of laser with you. This is a representative case I'm going to say, present in front of you. This is a patient who is 12 months old who got bilateral ureteric. The patient is first put in prone position, supine position, and with the small ureteroscope, you pass a guide wire, and over the guide wire, you pass a ureteric catheter. I always avoid putting Foley's catheter in pediatric patients because the urethra is also very, very delicate and fragile. So infant feeding tube is always passed by the side of this ureteric catheter. The size of ureteric catheter, usually we prefer to have between 3 to 5 French. Smaller the child, 3 French is preferred. And this guide wire, this ureteric catheter and infant feeding tube is always fixed to the thigh while doing prone position. Then the RGP is done as we do in routine cases to know the exact anatomy. Marking is always done for the ribs and the iliac crest. So the puncture is you got control on the puncture. Once you are confirmed which calyx will be punctured, then you go through the calyx. Now you see in the second video how the kidney is hypermobile. So while you pushing the needle, you have to be very gentle, and it has to be. It is like a thrust movement. You should not directly push into the kidney. So this is a monoplanar puncture where the calyx which you want to puncture has to be indented by the needle, and then you slowly and thoroughly jerk it into the calyx. Once the calyx is punctured, then you can see a normal clear saline which is coming out. Second thing I want to just warn you, your hands are always under radiation exposure in pediatric patients because the patients are very small and CM is right on your top. So always wear radiation protective gloves if possible. Sometimes I do use 18-gauge spinal needle because if you have seen the needle earlier, the routine needles are quite long and the lever is very, very high. So the chances of slipping the needle while pushing the guide wire is very high. So sometimes I do use 18-gauge spinal needle, which suffices the purpose of puncturing the kidney. And you see, the needle is short, so the puncture becomes very easy. So 18-gauge spinal needle is also a good choice for pediatric patients. Once the puncture is done, the guide wire is passed, and over the guide wire, screw dilator, and just make a screw movement and gentle drilling movements and reach up to the calyx only. Never ever over dilate, just reach up to the calyx, never enter into the pelvis. Because while doing that, the chances of getting torn onto the infundibulum and the pelvis is very high. So the dilatation should only be up to the calyx. Now see, once the screw dilator is used, then the rest of the dilatation becomes very easy. Now I am pushing that metallic dilator after removing the screw dilator over the guide wire, and it just passes easily. So this is the advantage of using screw dilator first, followed by metal dilator. Because if you directly put the metal dilator, sometimes the kinking of guide wire is very high. So better to avoid that and use screw dilator first, followed by metallic dilators. Once the metal dilator is passed, then over the metal dilator, you just pass the sheath, and that just goes easily into the system. So this movement has to be screw and absolute drilling movements, not thrusting and pushing into the system. And once the sheath is passed, the rest of the things are same as in adult PCNLs. Once the position and the tip of the sheath is confirmed into the system, pass a scope, see the stone, and just fragment with the laser. You can have choice of using laser if you have. If you don't have laser, even a routine lithoclass will also solve the purpose. And this is how we fragment the stone with the laser, and the whole fragments comes out without using any forceps. So make a negative pressure into the system, then take out the nephroscope, and the fragment will just come out along with that. So you hardly need any sort of accessories or any sort of forceps to pick up this fragment. And once we are clearance of the stone confirmed on your CM and nephroscope, you call it for the day. DJ stenting is optional. If the system is very edematous of the stone is at the PUJ, or if suspecting some ureteric problems, then put a stent. Otherwise, stent is not necessary in all the cases. And this is just a small puncture mark which is seen. In few patients, I do use 2 tracks, but these are all adult patients, adult pediatric patients who are about 10 years of age, where there are 2 different calcium stones, or they got strigon stones. This is a simple system which is required, which is same as adult PCNL. So up till now, I have done more than 118 cases of pediatric PCNL. 95 were male and 23 were females. The age range of my pediatric PCNL was from 6 months to 24 months. And single track is used in most of the patients. There is hardly any complications seen in either of the patient, and all of my patients, they discharge on second day evening. There are other technical aspects I discussed earlier, but I'm not going to touch all these things because of lack of time. So pediatric PCNL or mini perk in pediatric stone disease is very suitable and safe procedure, and can be used in all the pediatric patients of any age. Thank you. There are various papers which will suggest pediatric PCNL is really a game changer. Mini perk is really game changer in pediatric stone disease. Thank you.
Thank you, Kishore. That was a good presentation. Now we have all done the PCNL and we are in trouble. So Dr. Rajesh Kukreja is going to bail us out of the trouble. Rajesh, over to you. We have created the complications for you.
I'm not allowed to participate while the other participant is sharing.
So, Kishore,
yes,
your talk is over. Okay, Rajesh, now you can start your screen sharing. We have done all the problems. Try to bail us out.
खाऊंगा मस्ती नहीं करूँ खाऊंगा
Rajesh, you are on.
I'm on, but I don't know. I'm not. Yeah, okay. Now I got it. Yeah, is my screen visible?
Yes, absolutely.
Yeah. So thank you, Satish sir, and thank you, West Zone Council, for giving me this opportunity. And this is a troubleshooting in PCNL, where I'll be covering a few aspects of where you get into problem in the PCNL. So 1 minute, let me just play it. Okay. So first is to simplify complications is the first essential of success. So if you understand where you're going to go wrong, probably you may not go wrong. So let's go to one by one the complications and troubleshooting. Lost or a slipped tract in PCNLs. Well, for beginners, there comes the most important slide that you always need to have a safety guide wire, because when you may slip out and you may not be able to enter. So for people who are starting to doing percutaneous nephrolithotripsy, it's always better to have a safety guide wire, and you can either do it by a alkane cannula or by a Teflon. You have these catheters from Boston Scientific. So if you have a safety guide wire, probably you may never land up into this situation. But as we get experience, and as most of us, probably more than 90%, would not be keeping a safety guide wire in the system. And now, especially when you're doing mini perks, you tend to remove your existing guide wire as well. So you are operating without a wire inside the system. So how do you prevent? The basic essential of every step of PCNL is a very good puncture. So maintaining the length, the angle, the depth, the direction of the dilatation is very important. So the straighter the puncture, the straighter the tract, less likely are you going to miss it. Every step of dilatation should be monitored on fluoroscopy. And what is important is the each dilator should be passed in the same phase of respiration as of the puncture. And the dilatation should be always by rotating movements at the wrist joint, that is pronation and supination, rather than forward thrusting. Forward thrusting, you're likely to kink the wire and then go either anterior or posterior to the renal system. The collecting system should be always distended during dilatation by saline flushing, and free exit of the flush saline from the dilators confirms that you are in the system. And a very important test, which was initially invented and published by Dr. Ridorkar, is the guide wire friction test. If your guide wire keeps moving in and out at every step, you are well within the system in a proper direction. So now let's see that you've taken all the precautions, and now somewhere in between your procedure, you've lost the track. You tried to remove a fragment and you slipped out of the track. Now what are you going to do? So the next is important question, is the wire is in place? So the wire is in place. Well, nothing to worry. So you load the guide rod and select your Amplat's dilator corresponding to the sheath size which you've been using, and put it over the wire into the system, and reposition the sheath over the dilator. And once you get free flow of saline flush through the ureteric catheter, you are well in the system. But now the tricky situation is when your wire is not in place. Then what are you going to do? So what I do is I pass a slender scope without the sheath. Try and identify the calycial mucosa with CM guidance by moving anterior and posterior. And this is generally possible when my tract is straight. But if my puncture has been too much up and down adjustments of anterior and posterior direction, that it was not a straightforward puncture. So that means the tract is oblique. And an oblique tract, you may not be able to get this. So then you pass methylene blue or diluted betadine retrogradely and try and identify the right path and place the guide wire. Well, if this too fails, you're not getting the system, then unfortunately a new puncture may be required, and the new puncture would be very difficult, as whatever contrast you try and put from below would extravasate. So choosing an access through a different calyx or a sonography guided puncture may help you bail out of this mess. And unfortunately, you may have to stage the procedure very occasionally. So second troubleshooting is perforation with stone fragments going outside the pelvic calycial system. So where are you going to land up with perforations? One, medial pelvic wall perforation with fragments medial to the kidney. When does this occur? You either overdilate it or you used excessive pressure by pneumatic energy. Now, excessive pressure by pneumatic energy very commonly occurs when you're doing mini perk, and with a thin pneumatic burr, you try and break the stone, and the stone actually, because of the pressure, breaks the medial pelvic wall, opposite wall, and then you see the wall is torn and the fragments have gone out. Second is you have dilated too much, over dilatation or torque, and that leads to infundibulocalycial tears and then fragments going anterior or posterior to the kidney. Third, a slip tract. You try to remove a fragment with the forceps and your sheath also got pulled because you are trying to remove a bigger fragment, and the fragments have got lateral to the kidney and they're now lying in the perinephric space. So these are the three types of perforation and situations you can come across. So what do I do with this now? So overdilated pelvic wall perforation, you withdraw the implant sheath, you will be having extravasation of fluid, loss of tamponade, bleeding from the pelvic wall, all these take place. So now, even for infundibulocalycial test, so now you judge what is the size of the perforation and what is the size of the stone or amount of stone fragments which have gone out. Small size of perforation, and you can see the few fragments which are out. Continue the procedure with hemodynamic monitoring. Look for the stone fragments which have migrated outside the system and try and retrieve them. But now, unfortunately, your perforation is very big and you start getting oozing from the infundibular wall or the pelvic wall, and you got large significant fragments which are outside the system. It is better to insert a nephrostomy tube, clamp it, because you may land up into extravasating lot of fluid there. And we all know there is fluid absorption which takes place during percutaneous nephropathy, and that increases significantly when you've had a significant perforation. So it is better to insert a nephrostomy tube, clamp it, stage the procedure. Now, well, everything is done. What is very important is this, that you need to document this very well in all your documents, discharge summary, OT notes for future reference. Otherwise, those fragments which are lying outside the system would always be seen as probable stone recurrence. So if possible, do a RGP on the table, document, and then mention it that yes, these fragments were outside the system. And so in case the patient comes back at a later date, you may not remember this. So you should be aware, or if the patient goes to some other urologist, he should know, yes, that these fragments are lying outside the PCS. Then comes to the most dreaded complication, and what we are all worried about regarding PCNL is the bleeding during PCNL. So I'll just skip this slide. Yeah. So we know bleeding occurs because of injury to the blood vessels, laceration of the kidney, multiple tracts, size of the tracts, and unfortunate formation of AV fistulae or pseudoaneurysms. When does the bleeding occur? Intra and perioperative is 24%. Early postoperative, that is day 2 to day 7, is 41%. And delayed bleeding generally occurs 35% of the occasion. So these are the rough, if you divide the occurrence of bleeding time-wise. So we all know, how do you identify? Is it venous or is it arterial? Venous bleeding can be well controlled easily by conservative measures because the intrarenal venous system is quite resilient. But it is the arterial injury that results in severe bleeding and which obscures your vision and makes you abandon the procedure and can land up into serious, difficult situations. And the delayed bleeding generally are because of pseudoaneurysm formations and then subsequent ruptures. So now let's see what happens. Now you are doing a surgery and you are landed up into intraoperative bleeding. There's significant bleeding going on. So what you do first is try and adjust the implant sheath. Your implants may be partly in, partly out, and or the nephroscope sheath. Assess the hemodynamic status and raise the fluid, give it under pressure, and then see. Okay, now I see that the vision has improved. Patient is absolutely hemodynamically stable. I've adjusted the implants, and so most likely this is a venous ooze which is going on and which has been taken care by increasing the irrigating fluid pressure, adjusting the implants. So I continue the procedure with hemodynamic monitoring and finish it. But the problem is my bleeding is persistent and the patient is now hemodynamically unstable. So what do I do? Well, then I infuse IV fluids, I give colloids, assess what is the remaining stone burden or how much time I'm going to require to complete this procedure. So if the procedure is nearing completion, I clear the remaining stones quickly and insert a nephrostomy tube and clamp it. If significant burden is remaining, it is always better insert a nephrostomy tube and clamp it and stage the procedure for a second day. So yeah. So then post-operative, hydration, antibiotics, regular hemoglobin, hematocrit, creatine, ultrasound. Why ultrasound? Clots in the PCS, perinephric collection, and importantly, clots in the bladder, which will all give you a hint towards what is going on inside. Avoid straining like vomiting or constipation, and do not restart the anticoagulants which you may have stopped before the procedure. So now, when am I going to take the patient for a second stage procedure? Patient is hemodynamically stable. There's clear urine from the nephrostomy tube and the perurethral catheter, both. Minimum 48 hours of staging, minimal tract dilation subsequently, and limit the procedure time to as low as possible and finish the job quickly. So, as I said, monitor all your pulse, blood pressure, everything, color of the urine from both the catheters, ultrasound for perinephric collection, clots in the PCS bladder, declamp the nephrostomy 4 to 6 hours later, assess for the color of drainage. If fresh bleeding, reclamp it and then declamp 24 hours later. So now the situation is you are getting clear urine from perurethral catheter and the nephrostomy tube. Patient is hemodynamically stable now. Then you can go ahead safely for a second stage PCNL after a minimum gap of 48 hours. And if you finish the procedure, might as well remove the nephrostomy. Now you got clear urine from the perurethral catheter. There are no clots, but there's a persistent hemorrhagic drainage from the nephrostomy tube. Patient is hemodynamically stable. So what do I do with this? Probably you need to check the position of the nephrostomy tube. It may have slipped out partially, or the tip may be abutting against renal parenchyma and not allowing the bleeding to settle down. Remove the nephrostomy, observe for 48 hours. If clinically stable with clear urine output and no collection inside, then you may subsequently go for a second stage PCNL at a later date, depending on your experience and through a separate calyx of entry. But now the worst situation is patient is hemodynamically unstable, has consistent hematuria or hemorrhagic urine from the urethral as well as from the nephrostomy tube, may have clots, may not be having clots, and there's a constantly falling hemoglobin or hematocrit. There's no other option left but to take the patient ahead for angiography. So, persistent or recurrent hypotension, bleeding from the nephrostomy, falling hematocrit, clots in the bladder, growing perinephric hematoma, failed conservative treatment, vascular shock. If either of these conditions are present, well, it's time to go for angiography. So this is the literature which was done in the CROW study, and that is what they found. 1.2% patients out of some 5,000 PCNLs which were reviewed, 1.2% required angioembolization. So you need to keep this in the mind. And out of these 1.2%, the commonest finding was an arterial pseudoaneurysm in 47% and an AV fistula in 22%. So 10 patients had more than one angiographic finding, and that's it. And these are all the ways which you do an embolization. This is just a simple case I'll show you. A 31-year-old male with a right apoatric stone, gross hydronephrosis, failed URS, failed 2 sittings of lithotripsy, and we did his PCNL. 1 hour finished, hemoglobin drop of 1.1%. Patient was discharged 48 hours later with clear urine. He presented on the 5th post-op day with frank hematuria, fever, and ureteric colic due to clots in the PCS and ureter. Hemoglobin drop was 2.5 grams after the discharge. So we did a cystoscopy, we removed the clots from the ureter which were visible at the ureteric orifice, and we put a stent to deobstruct the kidney. Again, he was discharged after 5 days of observation with clear urine and no drop in the hemoglobin. Now again he comes back a week later with clot retention, clot evacuation done. Patient is hemodynamically stable, urine is clear, but now his hemoglobin has dropped not much, 0.6 grams, but totally he has lost 3.5 grams since the pre-operative level. So, but now this is occurring recurrently. So then I decided it's time to move ahead with a angio. And this is what we found: a right renal peripheral arterial, very small peripheral vascular injury. And he was taken for angioembolization. Supraselective angioembolization was done. And this is the normal Doppler study after the embolization. What is the role of intervention? Bladder clots needs clot evacuation, irrigation. Obstructed kidney may need a stent to be placed. What is the role of exploration? Hardly any in today's world. You should have some backup facility, or you need to mark out, yes, I may have this problem ever in my life. I need to have an angiography facility available. So non-availability of renal angiography, patient in hemorrhagic shocks are the only 2 indications of exploration. So how do I prevent bleeding? So plan the perfect puncture, straight line traversing minimum parenchyma, enter the cup of calyx in line with the pelvis so that the puncture is straight, not oblique, and dilate always, as I told initially, always by simple rotating movements and minimal forward thrust. You see the rotating movement, and you should have clear urine when you punctured. So miniaturization of the tract, then avoid torque or angulation. These are simple steps which will help you reduce the bleeding, and make sure that you control the infection, rule out bleeding disorders, stop any anticoagulants 5 days prior to the surgery. And these are all routine things which we all take care. So factors affecting blood loss, you all know the operative time is the most important, and the tract size and multiple tracts. These are all important factors. Well, to conclude, all life is fragile, and no matter how much we fight to control its outcome, all we can do is to live in the moment and survive the moment. Thank you, sir.
Thank you, Rajesh. Again, as usual, a brilliant presentation. All the speakers have done a great job, and the journey from the skin to the stone has been absolutely without any problem. Gaurang, are you on?
Yeah.
Okay, so I hand over the mic to Dr. Gaurang Shah, our secretary, to make the concluding remarks. Actually, we have overshot the time, but then the participation has been 100% throughout. So I must apologize because Rohit had told me that let us increase the number of participants. I said, nahi, shayad 100 nahi honge. So let me apologize to whoever has missed out. Anyway, Gaurang, over to you. Thank you so much to all the speakers.
Ulas, I think you had underestimated your effort and your speakers. Till now, whichever webinars we have done, probably this has, gathered the maximum number of people's attention, and everyone wanted, because I'm getting lots of messages that we are not able to join. But don't worry, we are going to put it on a YouTube. So later on, everyone can watch it on a YouTube. So as I said earlier, this is just the beginning, and the best is yet to come, and that is our West Zone conference. So I request all those who have not registered, still there is a time, please register and come there for a bonanza. Thank you. Thank you very much.
Thank you, everyone, and good night. It's time to end the meeting.
Good night, sir. Good night.
Good night.